here online. Welcome Shahid, welcome Ingrid as well, and Alice, thanks a lot for joining us. So do we have any apologies for today? Rebecca Margetts, Alison, who's an expert in this area, thank you very much for joining us. Minutes of the previous meeting. I read them through, and I must say that Madeline did a great job with the minutes. I thought they were really well written. Thank you very much, Madeline. Obviously, you know, some of the thorny topics that we discussed and challenging topics were, I think, committed in a very professional way to paper or to a Word document. Particularly, I'm thinking about the Woking Medical Centre and the lack of minutes for PPG, or you know, any sign that it is alive. However, that was confirmed as a contractual requirement, so that's something we will continue to follow on. Has anybody got any questions or omissions, errors, typos from the minutes? Everybody okay with them? Okay, that's great. Thank you very much. Any declarations of interest? No. Any public questions? Member questions? Super. So we're back to Coroner's Service. So I'm very pleased to that Matthew College, James Crosby, can join us tonight. Thank you very much, gentlemen, for joining. And we are all ears because this is a topic we know very little about. So this is going to be, I think, a first for the HOSC, is to have a presentation from the Coroner's Service. So we look forward to your presentation.
Oh, yeah, thank you, James. Yeah.
You have to speak into it as well.
Right, yeah, I am used to using these. I just completely forgot it was there. So, yeah, thanks very much for inviting us. You know, and very happy to come and talk about you know, an important service that we manage in Reading. So, yeah, my name is Matthew College. I'm the Public Protection Manager, and so this is one of the services that falls under my remit. And James, do you want to introduce yourself?
Yeah, good evening. I'm James Crosby. I'm the Assistant Director, and I look after planning, transport and public protection. It's a bit of a diverse service, but Berkshire Coroners falls under that area. Thank you.
So I don't know, you just said you don't know much about the service, so that's good. I know where to pitch it, and I think it's fine because I'm going to go into a little bit of detail about the service, so so that's okay. Looking to clarify, you know, the roles of the coroner and how the local authority fits in. Some of the sort of key performance indicators that we've got, and looking at service improvements that we put in place and some of the pressures. So hopefully you'll find it interesting. It's important to point out that, you know, we're local authority managers, we're not coroners. So you know, coroners are independent judicial officers, and so I'll be able to speak about the service, but not about coronial matters as such. But I'm sure you won't ask me questions about that. So we Reading lead on the service on behalf of all the authorities in Berkshire, and we operate under a joint arrangement. We're located in the town hall in Reading. You're very welcome to come and visit us, and the inquests are all open to the public, so please do come along. We've got excellent facilities there. 2 courts in the town hall, a large court and a smaller one that we can run simultaneously. And we've also got a jury room, and we've got office facilities there as well. So all the staff are located there, and the coroners. It's not always the case across the country, but that's what we've got for Berkshire. Heidi Connor is the senior coroner. She's a full-time post, and we've also got an area coroner starting the end of this month, who is also a full-time salaried post. 7 assistant coroners, so they sort of operate on a casual basis. They sit when the coroner needs cover, or to get through the workload. So yeah, that's the main staff. So this is just on your slide. There's just a brief description of what the role of the coroner is. That's from the chief coroner. So small but important part of the justice system. Primary purpose is to investigate deaths that are violent, unnatural, unexplained, or that have occurred in custody or otherwise in state detention. So there's 4 statutory questions that the coroner usually has to answer. That's who the deceased was, when, where, and how the deceased came by his or her death. So that's in a nutshell what the service does. But on the next slide, that breaks it down a little bit more. The bereaved is central to the functioning of the service. They're at the heart of the service. It's very much, that's what we aim to provide, a sympathetic service to the bereaved. So, and provide answers about how their loved one died, and assurance that there's been an independent judicial process. Coroners also contribute to the accurate registration of deaths, part of the death certification system. They carry out enhanced investigations around Article 2 of the Human Rights Act. That's around where there's deaths in where the state is in care or there's or in custody. And they also consider where prevention for future deaths. I'm sure you will have seen, you can't not have seen in the news that a very sad death around the Reading teacher Ruth Perry, and the inquest that's recently happened around that, and the Section 28 prevention for future death report, which was widely reported nationally, internationally from the coroner, still hearing it this week. I heard it on the news referenced again. So that's an important part. And the final point on there is just to say about that there's another a role around treasure, which sounds really exciting, but I'm really not going to talk about it. It's quite a small area, and yeah, and we'll probably have to save that for another day. So moving on to the role of the authority. So the local authority's responsibilities fall under the Coroners and Justice Act 2009. And within that, there's a duty that the local authorities have to fund the service, basically. The wording's there, but it talks about accommodation and staff, but really it encompasses all funding for the service. So I will go on to talk about the major sort of expenditure areas a bit later. So some key numbers here. Just the numbers at the moment on the first slide. Just over 7,000 deaths reported in Berkshire, and of those, about 30% are referred to the coroner to investigate. 871 post-mortems. I'll talk about those in a minute. And of those post-mortems, there's a proportion that needed histology, which is around tissues, and analysis and toxicology as well. That require extra analysis. CT scanning, I'll come on to as well. Quite a small number there, and I'll go into a bit of an explanation about why that is and how that area is developing. And we carry out 438 inquests, so a lot of inquests. Some are 2 or 3 weeks long, some are a couple of hours long, but that's the sort of outputs we have. So we provide statistics to the Ministry of Justice every year on the service, quite a lot, and they provide they publish national figures on the service, and also you can go online if you look for coroner statistics and find these, and they provide comparison with averages across the country. So just showing there that in some key areas. We're well, in line with the national averages. Post-mortems slightly under, but pretty much in line. And that's very much down to scrutiny by the service and the coroner to make sure that post-mortems, has to be carried out rather than, just using that as a default position. But that's a judicial decision. And The CT scans part was something I was just going to talk about at this point. The numbers there are low nationally anyway, about 12 or 13%. But in Berkshire, it's quite a small number at the moment. Now, CT scanning is a non-intrusive way of carrying out a post-mortem. It's can be very distressing for family members to find out that their loved one is going to undergo an intrusive post-mortem. So CT scanning is being brought in across the country. It's sort of going at different speeds, really, and it's really dependent on availability of a CT scanner and the cost. So that's something that we're actively looking at to develop, and it's something that I'll come to talk about some other issues where it will complement that work. Next slide is just around inquests. It's all blue, so some other colours might have helped, but basically Berkshire is right on the average about how long it takes to process inquests, which is on average 30 weeks. Now, some take a lot longer because of the complexities, and others are a lot shorter. But that is a good place to start, and I'll come on to some of the service improvements we've done. But by having the resources in place, the necessary number of coroners, assistant coroners, and area coroner, and having the courts available and staff to man them, really helps in bringing those weeks down. So we're looking for certainly a stable situation, if not improving the number of weeks, reducing the number of weeks that it takes to process inquests. So I've got this under major expenditure areas. It's part of the service and how we operate, but they are significant costs involved. So the mortuaries within that we use are based at two main mortuaries, one at the Royal Berks Hospital and the other at Wexham Park Hospital in Slough. Most Wokingham cases go to RBH, and the mortuaries are run by an organisation part of the trust called Berkshire and Surrey Pathology Services, which is a venture between 5 NHS trusts in the area, Berkshire and Surrey, as the name suggests, and we contract with Frimley Health as part of that. They cover Wexham Park, so we need a contracting body as such. They're the two main sites. We do have to use other areas for special cases, such as paediatric cases go to Southampton. So one area that I can bring in now is we're looking, the contract lasts till 2027. We're just extending at the moment. Normal procedure would be then to go out to re-tender. Obviously, there's not that many mortuaries choice around, but it's a developing area where some, for example, Stoke Mandeville has got a very large facility at the moment. So there could be other options. The other work we're looking at the moment is with our colleagues across the Thames Valley, considering the possibility of a regional mortuary, which is something that the chief coroner has advocated, and also our senior coroners across the Thames Valley. Now, that would be a centre of excellence that would serve a number of authorities. Now that's had we've gone through an options appraisal looking at really locations where that it could possibly be located. There's still a number on the table, and we're trying to move to the next stage, which is feasibility, really about operating that and what the costs will be involved. Quite a slow process, although we're getting to the point of having to make decisions about which way we're going. So in that regard, we've got to assess the benefits of, or the pros and cons of a regional against what we've got locally. So The local mortuaries are under pressure capacity-wise, so we have winter pressures. So in the past, we've had problems with mortuaries being able to take cases in, and where the death certification process slows down, or funeral directors have an issue with carrying out funerals, that all clogs up the system. With COVID, it was particularly difficult. So Wexham Park have already extended their facility and upgraded it, and the Royal Berks Hospital is also now quite a long way down the line of planning for quite a significant expansion as well. So we've got we will be bringing a paper to the authorities, setting out the options around that, I would imagine. So 871 post-mortem. So usually it costs about £500 a post-mortem. So it's quite expensive for the actual facilities and the storage. So that doesn't include pathologists. I'll come on to that in a minute. When someone dies in the community, and the police attend the scene, and they refer it becomes a referral to the coroner. The coroner has responsibility for that body at that point. So as a local authority, we have to fund the collection of those deceased, take them to the mortuary. So we do that under contract. It's a 24/7, 365 days a year service. You don't know when that's going to happen, and some of the cases are very harrowing, as you can imagine. So we've got a contract at the moment. We have had difficulties with it, not with the contract, but with procuring those contracts. It's very much been something that's been supplied by funeral directors in the past, and certainly in the last 5 years, and especially with COVID, funeral directors are less keen, to put it that way, to get involved, and that has a knock-on effect because who else provides that service? So we've actually got a contract at the moment with a company that was new to the market, who aren't not a funeral director, and they've provided a short-term service, which we sought additional funding for from the local authorities at the time, and we're coming to a critical point in the procurement process at the moment, and we're considering a number of options. Can't really go into any more than that at the moment, but it should be resolved within the next few months about which way we're going with it. But we're just within that procurement process. So that's another area that's a major expenditure, but it has to be provided one way or another. Like everything involved with this service, really. Pathologists, next slide. So that pathologists perform the post-mortems, and there is a lack of pathologists nationally. This has been, can you have a growing lack of pathologists? But that the problem's been growing for some time. There's not enough autopsy trained pathologists in the country. They do not have to do this work anymore, whereas in the past it was part of their role. A couple of other reasons why they are less keen is that the fees have not been reviewed since 2013, and in practice, most local authorities have to pay above the fees to get the work carried out. The MOJ, Ministry of Justice, are carrying out a review of fees at the moment, but it's taken quite a long time. Royal College of Pathologists, Chief Coroner, it's been raised at a select committee, but there's been really little activity, that's helped the situation. And coroner's work is not part of pathologists' NHS contracts, so they have to do this outside of their normal duties. So one of the aspects of the regional mortuary was, and the local option, is to try and look to see how we can encourage pathologists to to carry out this work, and that might be around providing a centre of excellence or a teaching facility, or contracted, making the contract with pathologists part of the mortuary contract. So those sort of issues. So that's something that we're looking at the moment. Toxicology, that's where we have to carry out further tests, for example, drug and alcohol analysis. We've got a contract with the University Hospital Leicester at the moment for that, and we're just extending that for another 2 years. So there are a number of suppliers of that around the country, internationally, that we can look at, and that's a fairly effective procurement process. Another area, a cost area, is inquests, legal costs. Inquests are becoming more complex. There's a lot more challenge. There's a lot more expectations from families. There's interested parties around negligence issues and things like that are very well supported. The coroner might have to employ counsel to advise her or him on inquests. So, as you can imagine, there's legal costs associated with the inquest, as well as witness and jurors and that side of things. And there's also judge-led inquests, which where there might be an issue of national security, where the coroner cannot sit, but a judge is appointed, who also appoints his own legal team, and may choose a venue as well, a different venue. And there's no government policy on funding those judge-led inquests, and it falls to the local authority in the first instance. So next slide. So I talked about having the staff that we've got, and the area coroner and assistant coroners that we've got. Now, we in September 2022, ourselves and the senior coroner raised a number of issues around the funding of the service, and there was a call to increase that because of the pressures. So we go to Berkshire Public Services Network, to the Chief Executive Forum, to I don't know if you've got a question about that.
Please carry on.
Yeah, that was agreed to increase the funding, and since then we've appointed a number of new posts, and we got the approval to increase on the cost for the removals as well, funding for the removals as well. One area that's still to be decided is the bereavement nurse. That was a suggestion from the senior coroner, which would be a part-funded post with the NHS, and the proposal is for nurses to attend families of homes where there may have been a suicide in the family, or where there might be child death cases, and it's to support those families, and also to support staff within the service, because of the traumatic nature of the work that they've have to witness. So the service improvements on the next slide are really what we're trying to achieve with those additional resources, and what we are achieving. Certainly, having additional coroners officers has really helped with managing cases. It's certainly helping with dealing with the time scale, and in providing a really sensitive, sympathetic service to the bereaved. And we hope to see, as I was saying earlier, reduction in time to inquest as a result of those appointments. So the last 2 points just to focus on was around the capacity for senior coroners to focus on prevention of future deaths. So we do contribute to a number of data analysis around suicides, for example. Carry out an audit every year with a health practitioner on behalf of the whole of Berkshire for suicide deaths. We attend a West Berkshire Suicide Overview Group. I understand from the senior coroner that she's planning on meeting public health leads to discuss the Berkshire-wide suicide strategy, and she's also gone to Slough train station to talk to people about suicides and accidental deaths there. We also provide information where requested on issues such as deaths on smart motorways and where defibrillators have been used. So that's on a reactive type basis, and we also update the drug-related death overview panel. So the senior coroner is very keen on expanding that role to really bring some value to the prevention of future deaths sort of element of her role. The last one, there's the Chief Coroner recommendations. Chief Coroner is a post that was created under the Coroners and Justice Act, and they're influential, and they set out guidance for coroners, but they also set out how they see, or the Chief Coroner sets out how a local authority should fund and manage the service, and also just issues around the general challenges that the coroner service faces. So he carried out, he came and actually did a visit, didn't he, to the town hall. He did a tour of the country, and he's written a report in December 2023, which you can look at, which is a bit of a 10-year overview of the service. I just wanted to highlight some of the things that he highlighted, which are failings around the country, which we think we've addressed. So insufficient personnel, dilapidated buildings, insensitively sited accommodation, lack of dedicated courtrooms, a lack of area coroners, difficulties where police employ coroners' officers and we employ them directly, and you know, I can safely say none of that applies now to the Berkshire service. So I haven't provided much information on the budget. It's a headline there. It is all of the above, but it does cost a fair bit to service it. And Wokingham have a contribution to that, and we feed back on that through the Berkshire Treasurers on a regular update on those joint arrangement contributions. But so your contribution is about 18% at the moment. We've covered quite a few of what's on that future slide, but one thing to pick up on relating to the budget is we're going to carry out a review of the joint arrangement. That's now 10 years old, and it was done at the time when the coroner's offices were transferred from the police. So that does need a review, and as part of that, we'll looking at the apportionment of costs and clarifying some of that. So that's something that Wokingham obviously will play a part in, and also the last point there, the medical examiner service. That's been operating in acute trusts for several years, but it's now being moved onto a statutory footing from April 2024. So that means that all deaths in the community will be referred to the medical examiner before a death certificate can be provided. So that might mean that some of the referrals do not reach the coroner because the medical examiner scrutinised them. But what we will get is, and what we found with when the MEs were in acute hospitals, is that the more complex cases were highlighted, work did come to the fore, and those were all caught. So we're expecting the same sort of result there. So I think that's it. I think that's it. Yes.
Thank you very much, Matthew and James. Is it okay if we ask you some questions now? Questions from anyone? Jackie?
Thank you. It was very informative. I've just got a question about the map of time taken to process inquest. Presumably the average time for a post-mortem depends upon the cause of death, i.e. unlawful killing or murder. You'd have to have that quicker because, yeah.
Yeah, I mean, when there's a suspicious death, or that those then often considerations given to have a forensic post-mortem. So then the police obviously get involved with that. We from the budgetary point of view, we pay for a portion of that. The police cover some of those costs as well. But yeah, they're more, they're obviously carried out. Bit quicker. Yeah.
Alison, did you have a question?
Do you have any breakdown by borough of the deaths that the coroner's office deals with, or is it simply that's compiled by area?
We can do a breakdown because we, as part of the apportionment, we part of the calculations. We don't actually do this anymore because it's changed slightly, but was to work out where people died. Was important to know that. So I do know, for a fact that we can do that. It's what information you might want from that. That might be the question that we need to ask, but we can certainly break it down to Wokingham residents as such.
I mean, the 18% contribution looks probably like a sixth. So is it simply an equal split between the boroughs rather than, one borough has a far more deaths that require the coroner's office looking at than others?
Yeah, I don't know how far I should go back on this, but there used to be 3 coroners in Berkshire. There was West Berkshire, Reading, and East Berkshire, and so they were amalgamated into one. And at that time, the apportionment was generally set as it was when there were 3. So it did sort of take into account that, but there's obviously peaks and troughs about numbers. So we don't really delve down into how much individual cases might be, because some Wokingham cases might cost a lot more individually, but there might be less of them. So we don't really get into that analysis. At the moment, the apportionment is based on figures that started at the time of amalgamation, have been transitioning to make them a bit more equitable across the all local authorities. But because of where the acute hospitals are and where the mortuaries are, then those areas tended to have more deaths. And it could have been that people were residing in a different borough, but then ended up in Reading or Slough, and so the death number, you have higher death numbers there. So they're slightly skewed. So I think our view is that more even it is, the fairer the system, because of the contributions that we're all authorities are putting in, and it sort of does even itself out.
So it's really done by the number of population in each borough?
It's not, but that's something that is what we're looking to move towards. So it is in Slough, it's done on population, but the other authorities haven't moved that way. One thing I would add is that when the coroner's officers moved over from the Thames Valley Police, that part of the budget for the officers is done on is calculated on population. The other part of the budget is calculated differently. So it's quite complicated, and that's why we want to review it.
Thank you.
Phil next, please.
Good evening. I was interested to read in your service improvements about you're looking at more capacity for senior coroners to focus on prevention of future deaths, and an example you gave was improving suicide prevention strategies. Is that in a leading role, or is that as a consultative role in that process?
I think, you know, the coroner would have to answer that one. That would be my my view, but they have to be very careful about what, you know, how they get involved. I think, you know, prevention of future deaths are issued, they're publicised. Once there's a response required from the recipient, but then the coroner has no further involvement in that. So I think what the senior coroner wants to do is she wants to engage with the relevant groups and to see whether when deaths come in that can help form, you know, help form policies for those groups to actually then prevent them. So it's then I don't think, you know, it's using the data that we've got, helping those review groups really to put in place their own policies. They're not going to be, the senior coroners are not going to be the leading expert on that area. But I think what's maybe, you know, prevention of future deaths is certainly something that you can see is really expanding. That you can find they're all on the web as well, and they're just increasing in number all the time. And you see them in the press where the coroner is using one at a Section 28. But then it's up to those organisations to actually implement those, you know, changes to try and do that. So yeah, we're certainly trying to the senior coroner is trying to reach out to local organisations to see how she can input to help.
Shahid online, please.
Thank you very much, Matthew, for that informative and insightful presentation. Can you hear me all? Yeah. I have two questions. One of them is regarding the time it takes for the coroner service, you know, to place, and the second one is to do with the CT scanning bit, in, you know, not intrusive methods. Obviously, we know it's very distressful time for the family. You alluded to some of the answer to the first questions before, but still, what we're hearing from certain communities is that due to cultural and religious reasons, the burial has to take place as soon as possible. But it takes a long time for coroner to do, you know, obviously get the clearance, and sometimes it could take weeks, you know, and that is quite a, you know, obviously it just enhances and lengthens the whole process. So maybe you mentioned slightly because of the numbers. I just wanted to have a clarification. Is it just because you have a limited number of coroners in place, or is there any other reason, or somehow can that be expedited, especially for cultural or those religious cases? That's number one. Secondly, also because of some religious and cultural reasons, you know, families are not comfortable. Obviously, distressful time for them to see their family go through the normal post-mortem. They would prefer the non-invasive method, CT scanning. But I just see that, you know, in some cases, what I've heard is they've tried, but it is not available in Berkshire. What would be the process, you know, to go about if a family wants to have a CT scan and non-intrusive method, would that be family have to pay for that, or is there something services which is provided by the council? Thank you.
Yeah, no, they're two very good points, and something that the service deals with all the time. They're certainly very, very aware of cultural and faith aspects, and they do, they work as hard as they can to make sure that they're all expedited as quickly as possible. There are some cases where it's not to do with resources actually. Now it's where there's a reason, there has to be some analysis carried out, and it's much more along those lines. But we work very, very closely with Islamic funeral services, for example, who provide a really good service to help us support families. And it's something that it's dealt with on a daily basis, but just managing expectations and trying to meet those requirements. So it's mostly due down to whether a post-mortem is required, and getting that carried out, and whether any further analysis is required around how those cases are expedited. On the scanning side, yes, it's about availability of CT scanners. So dedicated CT scanners to coronial surfaces are quite rare, but they are popping up around the country. They're incredibly expensive, so there's different models of funding for them. The sort of ideal scenario really is to be able to use hospital CT scanners, but they're being used as well for other patients. We certainly have referred cases for CT scanning, and families have paid for scans to take place. We don't pay for that on behalf. If it's an elected CT scan, the council don't pay for that. That's down to the family. But as I said, we are very much pursuing options around CT scanning, and in areas where they have them, the majority of scans initially go through a CT scan, have a non-invasive post-mortem, and then some do then require an invasive one after that. But it does completely change the numbers, which we know that sections of the community would really, really appreciate. So that is a key driver in expanding that element.
Can I just come back on that one, CT scan side? I was saying that if a family has a choice, or no, let's say by default it will be a CT scan post-mortem if it is available. But if not, then family has got the choice also to go for a CT scan, but they have to pay for it. But what would be the cost of that if they have to pay for that?
I don't have a cost for you actually. I think it would vary really, depending on which provider it was. Obviously, we have carried out some CT scans, so sometimes it is appropriate that the coroner approves those, but we know that each case has to be looked at individually, but there also has to be a consistent approach. But yeah, there are occasions where if that's required and the coroner doesn't think that that's the appropriate route to, it's not the necessary route to go down, it's not the appropriate way of conducting the post-mortem, then it would be down to the family to pay for it.
Yeah, I mean, just on that point, I think most of the people I've come across, I don't think they're even aware they have the choice to go for a private CT scan. I think it'd be useful to share that information, or maybe through some communication that is an option available if the coroner gives a go-ahead, and then they can make that informed choice if they want to pay for that. And I know some families, they are willing to pay for it as well. I don't know what the cost is, as you said. it'd be useful to know what the cost is, and perhaps it can be communicated widely to say, look, there is a service available. If anybody wants it, at least they can make the informed choice.
So it certainly comes out in discussions with the coroner's officers and the family. So I do know that happens. So on individual cases, but if there are any instances that you know of, then you know, quite happy if you raise it, and then we can look into it if families don't feel they've had that information.
Okay, thank you, Chair.
I think it's Rochelle next.
You proposed a number of different new facilities at RBH, and do you realize that RBH is most likely moving someplace else? And if you're building a new facility there, it's going to be in the middle of nowhere compared to where the rest of the hospital will be. Are you taking this into account? Depending on when Parliament finally gets around to allocating the money to move them, but it is going sometime in the future.
I'll let James maybe want to come in on that, but just on the what they're planning on doing, they're planning on expanding within the existing footprint of where the mortuary is. So yeah, but James might be able to update on the.
Yeah, I'm sure colleagues to the right may have probably got a better update, but I think so. We know that the RBH are doing this as part of their overall plan and cognizant of the move and the new hospitals program, etc. So that's not being done in isolation. I think the wider point for us is that we are exploring those options around a regional function. We are absolutely aware that, and this is one of the reasons why the feasibility is quite complex, is that if we were to take a regional facility-led approach, the facility would probably be outside of areas which are easily got to. At the moment, RBH and Wexham are very accessible for Berkshire either way. If we would take a facility and move it elsewhere in the Thames Valley, that would be a significant potential additional cost to us. It would be perhaps more challenging for the bereaved to get to if they needed to. But with all of the challenges in the context that Matt set out earlier on around, the escalating costs of pathology, mortuary services, toxicology, doing what we've been doing for many years is probably not the option. We need to kind of review and think about doing something slightly different. It might be that we don't end up going down that route, but I think we needed to explore it and kind of either rule it in or rule it out, so that we're in a more informed position as we move forward with any sort of contractual discussions around maintaining those facilities. I think, as you can probably tell by the nature of the service, it's incredibly difficult to, you're not working in an average market situation where there's a lot of suppliers for these sorts of things. So that, we have to continue to explore options outside the normal in order to try and get best value.
Most likely location that it's going to be moving to is somewhere in Wokingham. So it's not that far away from RBH at this point. So
I think it was Al next, please. Wakey.
Okay, thanks. Just I'm looking at the figures. So total deaths in Berkshire is 7,096. Total deaths reported to coroner 2,257. So that's about a third reported to coroner. Now, is that because anyone who dies in a hospital or a hospice or in an old people's home gets referred to the coroner? It seems quite a lot are referred to the coroner. Is that a third?
It's no, not everyone. Not everyone does. The medical examiner service, if you die in hospital, then cases are scrutinised by medical examiner service first, and then some of those cases might get referred. So it's not an automatic. It's not an automatic referral. The change in the system with the MEs is that when there's a death in the community, they're going to go to the ME service first, unless it's one of those violent, unnatural, unexplained, which are definitely coroner's ones. So though that number could reduce because they don't fall immediately into the coronial category, but they could still get referred afterwards. And we get that with cases at the moment quite a lot where they haven't been referred and then they are referred, you know, just from attendance at scene by ambulance service or the police, and there's the decision not to refer it, and then it's later referred. So yeah, generally that number, the 2,000 mark, has been quite, you know, give or take 200 or 300. It's quite consistent, been quite consistent for a number of years.
I mean, I suppose just to add, actually, you know, your point about the number of sort of facilities where there may be, you know, somebody is detained or similar, you know, so obviously we have prisons, we have hospitals, we have care homes, etc. We have mental health hospitals. And so there are in our area quite a broad range of facilities which will, as you know, necessarily result in potentially a higher level of referrals than perhaps another coronial area. But I think, you know, when, you know, that's sort of taken into account in each coronial area is considered, you know, whether that average and that moving average is going up or down. So, you know, we have a sort of a baseline, I guess, based on the types of facilities that we have within our area. And as long as we're monitoring that as our baseline, then, you know, as Matt says, it maintains that readiness. We're not overly concerned. But yeah, if you compared it to another coronial area that perhaps only had one hospital, no prison, and etc., then, you know, we would have different numbers.
Okay, thanks. And just could you just explain? I mean, if there is an inquest, does the is the body held in mortuary until that inquest takes place? Then, no, right.
No, it can be released before then. So, you know, it's after obviously the post-mortem's concluded and that side of things. Yeah, no, because an inquest could take quite a long time to take place. So yeah, no, it's not always held.
Right, because I was thinking, because you often hear that an inquest being opened and then adjourned until the police investigation's taken place, which could take years or whatever. So yeah,
yeah, I mean, inquests could be opened and then a murder case could go to Crown Court. They might decide not to hold an inquest after that. Some inquests are opened as well for cases that, you know, obviously the actual main inquest is then a lot, you know, it's going to be months and months and months down the line. You tend to hear that with bigger cases because they're the ones that get in the news when they say they've opened an inquest, but that's part of the procedural aspect.
All right, thanks. And just and you mentioned, you know, like a high publicity case like Ruth Perry. I mean, because there was a lot of public interest in that, did that get brought forward, or do they all just go to the back of the queue? They all just join the queue, do they? Or if it's got a lot of public interest, does the coroner accelerate that to the front?
I think there's they like to. I'm talking on behalf of the coroner here now, and they do the scheduling. But I'm sure they want to bring all cases forward as quickly as possible. I don't think that was necessarily brought forward, as far as I know. It wasn't a really long inquest, actually. It was a week, I think, or 6 days. So in the grand scheme, it wasn't a really long one. So some of it's around scheduling, but it was very high profile. You know, a lot of national, international media there on every day, and so we knew that it would be it would be in the spotlight as such.
Okay, thanks.
Tony.
Thank you for the very interesting presentation. You said that the fees of the pathologists were last reviewed in 2013, and we have a shortage of pathologists. It seems an obvious answer there, but I just wondered whether the fees would be set nationally or whether they're by local negotiation.
The fees are set under regulation, but there has been local negotiation. That's the situation, because there's such a shortage of people that can do it. So this review that's you know being conducted at the moment you know, is very much focused on what the level should be. So it will be interesting to see the result of that and how that might affect our budget. But yeah, there has to be some local negotiation, else it just would not take place.
Yeah. Okay, thank you.
Beth?
Thank you. Can I say thank you for the work you did on Ruth Perry? I knew Ruth. I worked with her in the past, and she was a very good and capable head teacher. I just wondered a couple of these things here. If a family has a sudden death or a suicide or a murder, do they have to pick up any of the costs, or does the coroner's service pick up all the costs?
There's no costs that they pick up as part of our process. I mean, obviously there was the issue about the CT scanning, but there's no cost that they have to pick up. Obviously, they could incur legal costs if that was appropriate, but there's no cost as part of our service that they pick up.
And
I was just going to say, in terms of that legal cost, that would be them taking their own legal advice as opposed to us suggesting that they needed legal representation. And it could be that there are other parties involved in that inquest where there may be some future action that they're looking to take through the civil courts or criminal courts, and they feel as though they need to be represented, which, as Matt said earlier, is one of the trends, I suppose, that's happening with inquests. We're seeing increasing litigious behaviour, and therefore virtually every party in more complex cases will be represented, which then therefore means counsel needs to be provided to the coroner to ensure that she can conduct the proceedings openly and with mind to all the legal ramifications of the discussions that occur.
And could I just clarify something from Shahid's earlier question about CT scan autopsies? No, is that the right word? Oh, I'm watching too much American TV. Or silent witness. Is it a choice that you could practically offer to certain families who objected to inquests that were invasive? Is it practical to be able to do that, or is it not practical? Is it exceptional cases where you are able to find a CT scanner that can cope on a timescale with that? So it isn't possible for she to say to families, this is an option, ask for it.
It is more on exceptional cases at the moment. I think a conversation can be had around electing, but I think, you know, even that's going to be, could be, you know, restricted by availability. So there's not a clear process where we could guarantee that that would be available at the moment.
Thank you. That's what I thought you said, and I just wanted clarity on that. Thank you.
Alison?
I'd just like to ask about, I'm not quite sure if I mean risk assessment or contingency planning. If we were unfortunate enough to have a Lockerbie scale incident in Berkshire, obviously, you know, you're already under pressure of not having pathologists and the costs, and you know, what happens?
Yeah. Yeah, it wasn't something I added to the list, but you know, if there was a mass fatalities incident, then the coroner plays a central role in that. They're actually the ones that direct for mortuaries, temporary mortuaries to be put up, and so yeah, they play a key role. There's basically regional and national planning around those sorts of issues, and there's sort of contingencies around that. It could well have an effect on well, it would have an effect on a local area if it happened in your local area on the normal running. But yeah, we've got a Thames Valley wide mass fatalities planning unit, group of people that includes coroners and emergency planners and others across the area that has plans in place for these sort of incidents as much as we possibly can, and we would be supported by the sort of national national framework around mass fatalities. Want to say anything more on that?
I mean, you know, a good example actually of that sort of scenario, albeit not a immediate mass fatality incident, would be COVID. So, you know, we actually had some facilities as part of the Thames Valley Local Resilience Forum that stored in Reading. We were able to initiate some of that. And then Matt and I delivered a temporary place of rest at Wexham Park as part of that planning, so that in the event of increased number of fatalities that were being predicted at that point in time, the system would have been able to cope. And then that allows us to then obviously deal with the coronial process after, you know, we've secured the post incident, etc. So it does work. It is hard work, and it's not something that you know, anybody wants to sort of have to initiate, but if we needed to, we would be in a position to be able to deal with those sorts of incidents.
And all of that additional cost, would we get government help towards that, or would you have to go back to the borough councils?
I think it depends on the scenario. As an example, having had a discussion with the MOJ about terrorist-led incidents, as an you know, so in exceptional circumstances like the Manchester bombing, I believe, you know, they were able to get some funding to kind of deal with the issue itself, and then the inquest, etc., that occurred afterwards. But it's there's no policy, as Matt indicated earlier on. It's very much on a case-by-case basis. If it was a mass fatalities incident and it was, you know, located only in our area, as opposed to something like COVID, where, you know, the government did step up with some funding, but actually still local authorities ended up incurring quite a significant cost, which, you know, was dealt with, you know, at the time. So it will be, I pretty much would have thought, on a case-by-case basis, and it will depend very much on that scale and, you know, kind of national impact.
I'll summarise a few points and then we'll move on to the next item. We really appreciate you coming here. It's jolly good to see you. Thank you both for your time. I think you've given very comprehensive answers to our questions. Obviously, we would like to see you back with, you know, whatever your paper is, confirming your, you know, your review of the joint arrangement and the conclusions and recommendations from that. We would really appreciate that. But you know, I have to say, I'm very disappointed with the scanner answers. You know, the scanner percentage is very low compared to England and Wales. And one of the things that we kind of strive for is fairness. We should be striving for fairness and equality in all areas. And I feel like certain communities, certain religious views may be falling foul of this scanner issue. I can't imagine what it must be like when there is a bereavement in a family, to go to a family and to say, well, you know, you can spend hundreds or thousands of pounds to get a non-invasive post-mortem. This must be an incredibly difficult conversation, and something that, you know, sticks in my throat when I say it, really. You know, and I think we should be having basically the same service for everybody, which is, you know, that people should not be paying for this, to be frank. But that's, you know, my personal view. But again, lovely to see you. Thank you very much for your time, and hopefully we'll see you in a few months or 6 months or whenever you complete your review. Thanks a lot. So I think we move on to Helen and Sanjay now. Welcome.
think Sanjay's going to talk first about primary care strategy.
Yeah.
I
I can do. I can talk to the. I think you've all got the packs, haven't you? So if it's easier, I'll just do that if that's easier, and then I'll pull out the pertinent bits. So thank you very much for allowing us to come and talk about the strategy here. So my name's Sanjay Desai. I'm the head of primary care operations for Bob ICB. I've taken over part of Helen's old role and moving across. It's really nice to be here. One, I'm a local resident, so I live in Woodley, which is really nice. And so, yeah, I thought I recognised you as well. I think I've seen you around. I'm a pharmacist by background. I used to work in Boots in Woodley, so that could be where I've spotted a few of you. So it's really nice to be here, and thank you very much. I think the other thing, it's nice to be here because I think during the COVID vaccinations or in the surge, I worked with Ingrid and some of the other team as well. So it's very nice. So thank you very much for inviting us. I'm new to post, so I've taken over from Helen, but I've only been here about 2 or 3 months. So luckily, I've got my bodyguard here to protect me if I've got any questions. So in terms of why we need a strategy, so the second slide in the pack, they've got some of the demographic details there. So as an ICB, we look after a population of about 2 million people. Within that, we have about 156 GP practices, 51 primary care networks, about 200 dental practices, and about 250 pharmacies. So when we are talking about primary care, we are talking about GP practices, pharmacy, optometry, and dental as the full shebang here. If we go on to the next slide, in terms of what the approach to developing a strategy. So there was the Fuller stock take, which was developed by Dr. Claire Fuller back in 2022. And as a result of that, we started looking at what we want to look at as an ICB. We underwent some focus groups together with patients, with GP practices, with optometrists, with dental, to look at actually what is there, how can we do that, and as a result of which we then looked at the data that supported this. We had a system-wide workshop back in November, I think it was, of 2023. I don't know if anyone attended or somebody in the patch would have done, and therefore we then produced the draft strategy, which is here at the moment. If we want to go to the next slide. So we are in the engagement phase of this strategy at the moment. So the engagement will go on until the end of February, and we are consulting with as many people as we possibly can, patients, focus groups across the patch. In terms of, Oh, yeah, sure. Yeah, sure. Is it don't know if I've got the link actually.
I think that's started, because talking to us, I'd like to
Our previous guests, their slides, they talk about everything I'm saying.
Oh yeah, sure. Yeah, I was going to just pull out the pertinent bits actually, just okay, yeah, but for people, yeah.
We don't
Yes.
We haven't got time.
Yeah.
I don't want it to rush.
No, not to wait. You sure? Yeah. Okay. Yeah. Connected into emails with them. Also,
Of yours, it's on stream.
I think your ICB Yeah, okay. Yeah, I heard you say that actually. I heard the word you say pharmacy, my ear pricked up at that point actually. So, yes, they've got robots there. Yeah, it's excellent. It's really good. Okay, yeah, shall I just carry on as, yeah, okay, I don't think it's connecting up actually. We can't seem to get the slides up, so I'll try and let you know what I'm talking about on the slide, if that's okay with everyone. The slide I've got up, which is the one with the 1 to 6 on, with the boxes on, for that one, what we're really saying is some of the strengths we've got as a system here. So when you, number one, is looking at GP practices, there's a lot of data around GP practice data, and depending on how you carve it up, we do fare well compared to a lot of the other regional targets. Number two is around the community pharmacy consultation service, which has just changed names as of today. So hot off the press, that's now become the Pharmacy First service. And this is a referral system from pharmacy over, sorry, from a GP practice over to pharmacy. In the region, again, we score well in terms of referrals. Number three is to look at some of the prevention work here. So again, we do have a strong focus on prevention and health inequalities in the area. Number four is population health management, and this is to do with the data behind it to help to drive some of our systems, our services. Number five is about flexible dentistry commissioning, which I'll tell you a little bit more about, but it's basically trying to look at the dental contract and apportioning a portion of that to some of the special groups which we know need extra support. And then number six is about the strengths of the system we are. So being a wider system, we do have economies of scale. If you want to go to the next slide. So they're all the positives, and now I'll tell you some of the challenges, which I'm sure some of these will resonate with you. So we know, for instance, in terms of access to primary care, we know patients do struggle to get appointments out there. Now, again, we've seen a 19% decrease in the positive responses of patients being able to get appointments. We also know that's also true for dental appointments as well. So we know dentists, and again, we as residents may have also suffered some of that. In terms of primary care workforce, we know that the workforce is under extreme pressure. Now, I've worked in the system for about 25 years, and I think I've never seen the workload pressures as they are at the moment. And we know that that's a fact for, I would say, probably GP practices, pharmacists, dental. We know it's across the board there. We know, for instance, number three is that the demand and capacity isn't matched at all. We know that the demand is more than the capacity you have within the system. And in terms of recruitment and retention in the patch, it is harder. So I think, and again, it's probably true for it is true for all of those healthcare professionals. We live in the home counties, which we know is expensive. We know to recruit into this patch is difficult. And I know with my old hat on as a pharmacist, pharmacies used to struggle as well. Actually, there was times that you couldn't get locums for want of money because of the way we are. And I think that it's probably got worse. Going on to the next slide, so our shared vision for primary care. So what we really want to look at is making sure that the patient is seen by the most appropriate person the first time. Now, in order to do that, we need to make sure that we've worked across the system and looked at all the different professionals to make sure we can support the patient the most effectively. Now, we want to make sure that we have if we can almost divert some of the patients with the low complexity needs to the most appropriate patient, we can then help to support those with more complex needs in a more holistic way with sort of patient-centered care as well. And then the third one is just looking at making sure we help everyone to stay well, which is ultimately what we want to do. Some of the enablers to support that will be workforce, obviously, in terms of helping patients. The second one is around digital and data. So again, making sure we've got the data connections between the systems, making sure that where possible, patients can book appointments via the electronic online systems or digital services, and where they can't, we still go back to the traditional way of phoning up or whatever. Estates is an enabler as well, and we know there are estates issues within the patch, and it's probably looking at the one public estates messaging that we want to get across. We did a focus group with some professional groups on one day this week. I've lost what day it is, and somebody mentioned within the BOB system that they're co-located with a community hospital. They've got capacity there. The GP practice want to expand, and so it's us working together as different systems, health, social care, across the board, to try and look at how we can work for the best interest there. The last one on the patch is about resourcing, and resourcing is not just about money. We're also looking about possibly moving healthcare professionals between different sites. So is it, for instance, moving the secondary care colleagues out into primary care and running clinics within the community as well? If we want to go on to the next slide. So we want to ensure that the right support is there for the first time. So exactly as I've just said, what we want to do is make sure that for patients, if they can self-manage their conditions, we want to try and encourage that and give them the support, give them the resources to be able to do that. You all probably know, when we come to winter, we have all those winter messages where we say, go to your pharmacy, stock up on your drugs cabinets. Being a pharmacist, I have to say that as well. But again, it's making sure that, that message is out there, but supporting patients to do that in the right possible way. If we can do that, it then means that the patients that are left, the more complex needs are then able to see for their, they're able to see their GP practice. And what we really want to do is for the workforce that we have, we want them to work at the top of their license. We probably don't want our GP practices to necessarily be seeing the sore throats, the colds, where patients can be referred to community pharmacists or other practitioners. In order to support that, we've got triage and navigation. So within GP practices, we've got care navigators now. And what will happen is those care navigators will direct the patient, depending on the need, to the most appropriate person. Within a GP practice, there's a sort of a multi-disciplinary team now. So you will have GPs, nurses, you have physios, you have paramedics, you have social prescribers. So there's a lot of different professionals as there were compared to maybe 10 or 15 years ago. And we want to make sure that the patient is seen by the right person. And again, with the initial contact, we want to make sure it's right. So again, if you've got some sort of musculoskeletal problem, make sure it's with a physio as opposed to going to somebody else. If you want to go to the next slide, this is about integrated neighbourhood teams and personalised care. Quite often in the NHS, we talk about putting the patient in the centre and personalised care. This is really making sure we move that agenda forward. Now, on the slide, you'll see the diagram with the circle and all the healthcare professionals around there. We want to make sure that if there's a patient with 2, 3, 4 long-term conditions, that that patient is seen with a multidisciplinary team, and it's got the right professionals to help support that patient with communication between them. And every integrated neighbourhood team might be different depending on what the patient's needs are and how they're supported there. I want to go to the next slide. The other thing that we're really keen is about the prevention agenda. Now, again, as a local authority and your public health teams, I know that will be high up on your agenda, and we've got to make sure prevention's in there, actually, because we know by doing prevention right, the patient will be treated right, and they won't then hopefully lead to other conditions in the future. So I know within the BOB system, we know there are deprived areas, and we know the outcomes from those deprived areas as not as favourable. We've got about 11% of our population who are smokers. We've got 3 in 5 adults who are overweight or obese. We've got 80% of the population who are not doing, I know I sort of look at myself as well at that stage, but breathe in. But we know that about sort of 3 out of 5 people, so 18% of the people don't do 30 minutes of exercise. Again, all of these factors are really important for preventing ill health in the future. If we want to go on to the next slide, nearly at the end actually, so I'll give you, I will shut up soon. We've talked about some of the work for the enablers for this vision. So again, workforce, as I said earlier, it's difficult to recruit in this patch. So what we want to look at is, could we look at continued professional development? Could we look at mentoring? Could we look at portfolio careers for some of the workforce here? That will help to give more satisfaction to our workforce and hopefully retain them, if not recruit people from outside the patch. Now, I know coming from a pharmacy background, I would have loved in my earlier days, probably not now, to maybe work a couple of days at the RBH, a couple of days in primary care, maybe one day in community practice. The thing that was holding us back is those HR passports or HR red tape. And again, if we want to really recruit the right workforce into the patch, to have that passport, employment passport across the different professionals. In terms of resources, as I said, we want to look at maybe moving the resources, and that's not just money, it's making sure we move the people around as well. If you want to go on to the next slide, digital and data. So again, using the facilities we've got, we have got NHS app out there actually, and get the message out to the public that you can book appointments potentially, you can order your medicines. Now, I don't know if anybody uses NHS app, but it is good when you can do that, but it's getting the messages out there to the public who can use that. A caveat to this is that we will never move to 100% use of NHS app. We still have to make sure for those patients who are not digitally enabled that there is another route as well. And I just want to really stress that, because I think that's sometimes the nervousness about moving to a digital solution. Again, I'm not on a promotion for the NHS app, but with the NHS app, you know, if you're a carer, if you've got a parent, there are functions available that you can order medicines for your parents, your loved ones as well. So again, it's just making sure that the comms are out there to support this. We want to make sure that the data is transferable, or the data between primary, secondary care is again linked, which in 2024, you know, we want to see that happen. And then last enabler is around the estates, which I've kind of mentioned already in terms of what is the art of the possible. If you want to go to the next slide. So in order to, our approach for delivery is again creating a focus. So some of the stuff you're seeing here is, you might think, well, what about all the other aspects? What we want to do is look at specific areas, because if we start to do everything, we know we're not going to achieve. So this is really for us to look at certain areas, do it right, and then move on to the next area, so that we can really gain and learn from that. There will be areas, so although we are a Bob system, we know that actually there might be local nuances and local teams where we need to work slightly differently as well. So again, it's mobilizing the strategic vision of what we've got across Bob, but also that local focus as well. And it's probably important to say, as an integrated care board and ICB that we are now, I think our role has probably changed a little bit, and we are really facilitators in order to change the practice there, and to collaborate with different system partners. Obviously, one of them is yourselves, to get things moving across the patch. Nearly at the end. So 3 priorities that we really want to talk about here is non-complex same-day care. Now, I'm saying that intentionally in a slow way, just to make sure we're talking about the right groups of patients. So these are those patients with low complex needs. So again, when I talk about sort of the coughs, the colds, the sort of the low, not the low-hanging fruit, it's probably the wrong term, but the low complex needs, making sure that we can direct those patients to the right resources that we have in the patch. And as I said, that will help, therefore, to leave the GP practices to work at the GPs to work at the top of their license and see the more complex needs. In terms of integrated neighbourhood teams, again, it's making sure that we get that wraparound care for those complex patients, because we know that 70% of health and social care spending is on long-term conditions. So if you've got a patient with multiple long-term conditions, we know that actually their needs are a lot more than some of the other patients, and we want to get that need right. The last priority is around cardiovascular disease. Now, cardiovascular disease is one of the most common causes of health issues within Bob, and looking at the stats, which has helped to support some of our strategy, we know that's an area we need to focus on, also because it then has an impact on, say, diabetes and all the other areas. So we're focusing on cardiovascular disease only so that we've got one area that we can focus on, and this is about making sure that we can do as much as we can around that area, do it right, and then move on to another clinical area as well. Again, the caveat to this is we are not going to stop, developments and service developments in other areas, but this is about how we can perfect the cardiovascular disease service provision and then move it on to other areas as well. And then next slide. So continue to focus on improvements. So again, in terms of general practice there, it's again the use of the NHS app and how we can support that. It's looking at supporting patients to navigate their way through and see the most appropriate prevention patient. Community pharmacy. So again, as of today, you've probably heard it, it's been on all of the newspapers and all of the news. Pharmacy First has just been launched today. So this is a new service where there are 7 conditions where pharmacists can have a consultation with you and give out treatment, including antibiotics. Now, as a pharmacist I know I look young, but of many years, this is a really, really big way forward for us as pharmacists. And just using that as an example, when I used to work in community practice, you knew what the patient needed and you'd have to say, I'm sorry, but I can't give out antibiotics. Go and see your GP. Within half an hour, they're back with a prescription. And it was just so irritating, I think. And you just feel for the patient because of red tape, they had to do this. This is a really good service where they can give you antibiotics. So my quick plug there for the new service that's just been launched as of today. With optometry, again, we want to cut down some of the bureaucracy around this, where you go to see your optometrist or optician on the high street, they say to you, oh, I need to refer you into secondary care. The optometrist writes a letter back to your GP. The GP then refers you. Why are we doing that sort of, middleman approach? We will now, have the connection so optometrists can refer directly into secondary care. So again, patients will be seen better and help to support them in a more quicker way. So dentistry, so we are one of the first areas in the country that we've looked at flexible dentistry commissioning. Now, you may have heard of this already, but this is for about 10% of the dental contracts. We've allowed dentists to be able to look at certain groups of patients who we know are more vulnerable and have greater health needs. Now, we want to look at how that's going and see if we can expand that across the patch in order to help to support some of those special groups of patients, really. In addition to that, I talked about prevention earlier on. We want to look at seeing if we can do more school-based assessments around eye care and dental as well, if that's possible, and making sure we can get that right. And then the last one is around community as well. So we've got some services where we call hospital at home or more home-based services. We want to bring the care closer to home, which, wherever possible, bring the community as well. Next slide just talks about how we're going to do this. And again, I'm not going to dwell on this, but we'll be doing bits at system level. We'll be doing it at place level as well, actually at local level as well. Then moving on to the next slide, which is a phased approach with cohorts. So again, we're going to look at doing pilots, if you like, or of doing some pieces of work in certain aspects and then moving it across the patch. I'm conscious of time, so I think I'm going to pause there, if that's okay, Councillor, and then open up to questions.
Thank you very much, Sanjay, and a really enthusiastic presentation. It's fantastic. Thank you.
Must have double pressed. Thank you very much. So a lot of this is recognised from my board meeting last week. However, the question that I left that meeting with was, you want feedback on the strategy. How are you going to achieve that? I know I recognise we've got dear Alice here and their ability to talk to the public, but if we really want to know, if you just stand and talk to random people on the street with no chance to think about it, they will give you, can't get a GP appointment, can't get a dentist appointment. But actually, if you give it to people in a way where they can consider how they might want to respond to this and how it might have been their family experience and friends experience and personal experience might affect how they want to put in to this strategy to give you ideas about actually what the community wants, then I think that I want to see not just a draft strategy, but a strategy for how you're going to get feedback from the public.
Absolutely, it's a good point. I mean, I think what we have been doing is try to go out to as many different focus groups. I mean, I went to the Ukrainian refugees on Friday just to find out. We've gone out to, we will do the digital means, on the website and all those aspects. We're going out to professional groups. So again, all of the healthcare professional groups as well. Again, Alice as well, actually, so we're going to Health Watch. I mean, if there's any other groups that, you can support us, please let us know. We will come out. I mean, we are ready to go out to any focus groups to hear. We want to hear what the public is saying, and we will go as wide as we need to and do that. So any ideas, any support, we are more than happy to listen to that.
Yeah, I mean, I get that, and I understand it. That all sounds great. However, I don't know what the percentage is, but I'd hesitate. It's in the high 90s of people in the community that are not involved in any focus groups whatsoever. But they all touch the health service one way or another. And this strategy, therefore, it might not deliver for them now, but it might deliver for them in the future. So I would like to think that there can be some further creativity. I don't know we can deliver it from here. I do know that you have very good comms teams that could do something just a little bit better, because this strategy, Bob being a new system, this is an opportunity to get it right now rather than wait and have to reformat it in 8-10 years time.
So can I just answer that? So I think that's helpful feedback. I mean, as Sanjay says, there's a lot of activity at the moment, specifically around this engagement period, and we have tried to cast the net as widely as possible in terms of the approach that we've taken, the means we've used and the groups that we've engaged with. But it will be an iterative process. The strategy will develop over time. So I think it's right that we consider how we build on the work that we've done so far to really try and broaden that engagement in the development of primary care generally, and in order for us to be able to check on progress and adjust as we move forward. But we would really, it's really helpful to talk today to you. Obviously, there's a lot of themes that we've discussed previously in this meeting and in previous forums, and the strategy hopefully builds on the work that is already happening locally. So whilst it's a new document and it puts a strategic framework around it, the delivery will be very much sort of locally based, building on initiatives and work that we've been doing for some time with our GPs and primary care networks, and we would continue to welcome your input in that regard, and anything you can do to support us in terms of receiving feedback from patients and suggestions around other ways in which we might do that. We would absolutely look to take on board.
All right. And with regards to the strategy itself, you may or may not be aware that Woking has taken a decision in council to actually go for a marmot environment that in Wokingham, which is looking at health inequalities. We've got a brilliant public health director who is going to be driving that. But I would like to think that strategy can maybe that you've got here give a nod to that, because that's going to be part of the collaborative working that's going to be required between the health services and the local authority provision.
Shahid, please.
Thank you, Sanjay. Really, a couple of things, Sanjay, you mentioned. I was really pleased to hear that, especially the pharmacy first. That's a great initiative, and I'm just surprised at why it has taken us so long in the UK to actually provide this service. You go around the world, you don't have that issue, right? And but here, obviously, in the UK, we do. So it's really pleasing. Same with optometry as well. This is no disrespect to the GPs, but in this particular case, they're not actually adding a huge value to it, and it should go straight to the specialist and etc., where the cases can be dealt first. And I'm speaking from personal experience, where my household members are. One is optometrist and one is pharmacist. Another one is a GP, and I hear from them. Sometimes they come home with a frustration. They say, we would like to escalate it. We like to help our patients, but there's a red tape which prevents us from doing it. So that's all positive stuff. Thank you for that. Regarding second point regarding strategy, yes, it's very important, obviously, engagement. We have the right engagement from the right audience to make sure everything at the start footing. But one thing I do observe is that around not only this particular case, but other situation as well, we spend too much time on strategies, but we don't get on with implementing these strategies. Residents don't see the benefits in these documents. They are just documents end of the day, but they see the benefits when these strategies are implemented. So my issue is implementation. And some of the stuff which actually is a common sense, is a no-brainer. You just need to get on and do it so our residents can see the benefit of that. One other comment, maybe a question, perhaps is, you mentioned in one of the slides the number of pharmacies we have, the dental practices we have, etc. Earlier on in PowerPoint, right? And I'm just was thinking, we had was it last meeting or the week meeting before, we had some representation from NHS England, and where we discussed that what we're hearing from our residents is, there is shortage of, we can't get appointments, etc. Maybe not enough GPs and pharmacies, etc. And impression they were giving is that we have actually done the analysis and they are the right, per capita, etc. But you very clearly said there's a disconnect between the supply and demand, and that is our observation as councillors when we go on the doorstep and canvassing, and this is what we hear from the people, and this is the same message we've been trying to pass on to the NHS England as well. So is that, why do you think that is the case? Is it that one group is not talking to the other NHS England, or there's a disconnect between how one group thinks and obviously our residents are thinking one way, but actually the NHS England they have a different view? Somehow we are not on the same page, and I don't know what can be done, perhaps with your wisdom and knowledge. Any suggestion that would be really helpful, because end of the day, resident wants to see appointments on time. They want to have NHS dentists appointments on time and all the other things. They don't want to wait for 2 weeks just to see a GP, or 3 weeks, 4 weeks perhaps to see a dentist.
So so I'll talk about the pharmacy side. So I suppose, and then Helen, you might have to come in on some of the GP stuff. So in terms of the pharmacy side, obviously we know there's been a lot of closures of pharmacies, and we've seen that locally, quite a lot. In order for a new pharmacy to open, it has to be written into what's known as the Pharmacy Suitable Needs Assessment, which you should all know about, because I think you guys or the Health and Wellbeing Boards will be writing those PNAs. So I think what's probably happened is the timings have sort of gone a bit skew with, because a lot of the PNAs around here were written about, I think it was earlier, sort of like maybe earlier in 2023, and then we suddenly saw a huge shortage of pharmacies where people were handing their contracts back, such as the Lloyd's pharmacies that we've seen across the patch. So I think the PNAs were written, and then obviously the pharmacies closed. So actually, I think the Health and Wellbeing Boards will need to look at sort of revising some of those the PNAs. And again, I can look into this actually as well. Actually, we can take this back, but I think that's where we would then be. We would be looking at where there are gaps in service around community pharmacy, because again, I know, living locally as well, I know where there's been some shortages there, and I think that's where maybe the disconnect is happening between what's happening at NHS England. So I think some of it is timing as well. I think, and I'll let Helen come in terms of GPs, but I think the other thing is to say is, around GP appointments, I think the demand and capacity is it's not matching up the two, and I think that's hence why we want to make sure that we're using all the resources we've got and the right professionals to support that.
I was just going to say, I'm not sure exactly which conversation is being referred to with NHS England, but certainly when we've talked about GP numbers here previously, we've presented sort of comparative information that shows the workforce statistics as a whole and how those compare to other areas. I don't think we've ever said that there isn't an issue in terms of recruitment and retention in primary care. For all of the reasons that Sanjay has outlined, workforce is a real priority for all of us in terms of thinking of different ways ways of addressing recruitment shortages and supporting practices and others to move to a more multidisciplinary team, which we've seen significant progress on locally. So it absolutely is a concern. I just wanted to pick up as well on the comment regarding implementation and not sort of being just having kind of strategies that sit on shelves, to paraphrase, but I think that's a concern that you're alluding to. And absolutely, we want this to be a kind of real document that really supports us to work with primary care to move forward and address some of the challenges that they are facing and the impact that is having on patients. I think one of the positives about this document is, and I did sort of allude to this earlier, but it does encapsulate a lot of work that's already happening, and we'll be able to build upon that work. So just to give a couple of examples for Wokingham, we already have well-established MDT or multidisciplinary team meetings and reviews for complex patients, and that's a model that people may be aware of has been operating across Wokingham for quite some years now, and so really well established. And I think the integrated neighbourhood teams described in the strategy will absolutely build on that approach. The other example I would highlight is the community wellness health check service that we've been working very closely with Wokingham Borough Council and with other partners across Berkshire West, which will launch shortly in Wokingham. Again, building on existing health check provision, but providing much more of a sort of outreach-based approach, again, tying in with the CVD prevention work within the strategy. So I hope that there's existing examples that we can build on and start to see some rapid progress linked in with this work. Thank you.
Alice, welcome, Alice, and it's your question time.
Thank you, Chair. Sanjay and Helen, one of the things that we have found during our so we know that we've just done the GP Access project, which is about to be published not long, but it's about the comms. For example, you alluded to the care navigators. People don't know what they are, and also to make you aware that they also question the credibility of a care navigator. So I think the part that I'm asking is, I think comms has got to play a big part in all this. That all these changes, because the public is aware, that they had so much changes coming one after the other. We have to be very, very careful of how we put all this out, and we've got to be very, very clear so that they understand what is happening. Because honestly, I mean, the NHS app, you alluded to it. People are confused, so comms has got to play a big part, and that's it. The other thing is also, are you planning to review this strategy? When is the review going to take place? Because you can't just simply go on and saying, oh, this is what's going to be happening. There's got to come a point where it's got to be reviewed to see whether it's working or not working.
Thanks, Alice. I asked you not to ask me any questions when I had a meeting with you earlier on, but I'll let you off, Alice, this time around. You make absolute valid comments, and I think Alice and I had a slight conversation earlier on when we had a meeting with Healthwatch. It is all about patient communication. Actually, we've got to get the communication out there, and we'll be really keen to work with the local authorities about how we can get that messaging across. It was a bit like the COVID vaccination. I don't want to keep talking about COVID all the time, but when we all worked together around the COVID vaccinations, it worked well. I know I subscribe to your Wokingham District Council newsletter that comes through every month. Fantastic. And that the numbers of people, and this is what we need to look at, how we can work together to get these messaging out there. And I think it is about messaging. You're absolutely right, Alice. I think if we can get the messaging right, that's where we're going to make the difference. The other thing I would say to you is, these aren't going to be changes overnight. So as Helen said, a lot of this is already happening. So there'll be incremental changes over time where we'll see patients suddenly ordering more of their prescriptions online. Again, to give you an example, pre-COVID, a lot of prescriptions were those dreaded paper prescriptions, which as pharmacists we hated. But the paper prescriptions there, suddenly because of COVID infections, we've moved to more electronic prescriptions. Now that was a huge sea change, actually, both for patients as well as healthcare professionals. But actually, now we're in a different era and we haven't got an emergency. We will slowly start seeing this. And actually, if you go to speak to a patient, I'd like to say in sort of maybe 5 years' time, they're like, oh, blimey, I used to order my prescriptions with a tick box and go to the pharmacy. Now I order it, on an app. So I think it is going to be incremental. We're going to build on the work we've already got, and we will then obviously carry on doing that. And again, it is about communications there. Your second point, I think, Alice, is probably builds on Helen's point. So the idea around the strategy will be we will ratify the formal strategy in around about May time at the board, after which we'll then develop the implementation plan. And, as the council over there said, we'll make sure that's a real robust plan of how we get that moving. It will be absolutely reviewed on a regular basis. We will learn what we're doing in one patch. And again, the beauty of being a big organisation like Bob is if something's happening in Oxfordshire and it's working really, really well, we will look to see how we can spread that good practice across the patch as well and bring it to Wokingham and all of our other areas. So I think we will be reviewing on a regular basis, seeing what the NHS changes on a regular basis, or whatever comes down nationally, we'll be moving with that, and we'll be absolutely reviewing it on a reg, and it will be iterative as time goes on.
Thank you.
Beth?
Thank you, Chair. And it's really good to have read through all of this to see what we're trying to make better for our residents. But the one thing that it doesn't and it can't address is that we are short of dentists. We are short of doctors. We are short of all the other professions, including pharmacists. And it doesn't and won't and can't solve that. And so there needs to be a different thinking and a different way of funding the training of doctors and all professionals. I mean, at the hospital this afternoon, it was very clear that everyone was working up here. And when we went in the pharmacy, it was just mind-boggling. And it isn't possible to keep that up indefinitely. That's why people leave the profession. It's far easier earning tuppence in Sainsbury's than it is earning £100,000 as the GP. And so we need to attack that and have that solved in a different way by government. We can't do it. It has to be a national thing to do. And until and unless that happens, the magic that you've got on here may not.
Phil? Sure.
I wanted to develop on that point actually, because I've been looking through and I'd noticed before, part of the strategy is about workforce, and clearly a lot of it delivering it depends on workforce, and there isn't really very much conversation in there about training and about trainees. There's some mention of apprenticeships and some other various schemes, but actually I work in mental health, and one of the things that we found is the more people that we train at the start of their careers, the more likely they are to stay loyal to us, or they're set down their roots because of the age that they are, and they form families and so forth. And I think that perhaps what this strategy is missing with regards to what Beth was saying is the opportunity to say, okay, this is a place which is known for being a place to do your training, to have your opportunities with GP practices, a trainee GP, whatever else might be, which I know that happens to a certain degree. Why not make it sort of a bit more of a headline, make it an attraction, and find people who are going to have longevity of career here? Because the thing is, once someone has trained, no disrespects to any places in the country, by the way, but once someone's trained and set up a young family, roots and a mortgage in Leicester, it's very difficult to move here as a qualified clinician of any sort, or healthcare worker. So I just would have liked to have seen a little bit more mention of that in the strategy.
Okay, we'll come back. Absolutely, and I think you're absolutely right, because I think we need to attract people into Wokingham, Reading, Berkshire, Bob, to get people here. And I know, again, sorry, keep talking about pharmacy world, but obviously that's one that I know of the most. I know I had colleagues who would jump on a train, going to London, which is half an hour down the road, get £6,000-7,000 London waiting, and actually it was there. So how are we going to attract those people into this area? And I think, again, I speak as a pharmacist, but I think if there are those portfolio careers where you can do a bit of this and a bit of that, where we can attract, that's going to support some of it. It's not going to go the full way, but I think your comment about, you know, the training and doing it is really important, and we'll make sure we feed that back, because I think we need to make sure we get that right. Actually, we want to get people into the patch and almost lock them in, and not, you know, move them up the ranks and move them across the different sectors if possible, but keep them here. And again, a lot of and that's why we're talking to the healthcare professionals. So actually, what is the struggles within dentistry and pharmacy and etc. and speak to those newly qualified people. How can we? What is your burning platform that we can try and resolve as part of this as well? But we'll definitely take that feedback. I think that's a really good comment. So thank you.
Ruth Bell.
I'd like to say thank you for including optometrists, because I don't know what the optometry training is here. In the States, it's exactly the same as medical school. And I've also done advanced work, and I was treating glaucoma, and I actually did some more work to do laser surgery as well, because you can do all these things, and it's spreading it out so you don't have to go see this person. You can see somebody on the high street who might be able to do some of these things. And it's a very good idea to broaden it out, really. It's very good. A lot of places aren't doing that.
That's just very quickly. I mean, we had a strategy day in November, I think it was, and actually there was the local optometry committee there, and they said, actually, you know, we might have resources within optometry. Actually, you know, please, can we work with you? And we're like, wow, this is fantastic, because we always hear of, we can't do it, we're overworked, but actually, could we look at, and this strategy will help to address some of that. So if there are eye conditions, you know, I don't know, say you've got something wrong, the first thing you do is go to your GP practice. Well, actually, could we look at a slightly different way? And could a possibility be we start commissioning service from optometrists to be able to do some of that? Perfect. They're the right person to see the condition. And this is about seeing the right person the first time. So it sort of builds on that. So thank you for that.
Oh, gosh, everybody's turning up now. It's like buses. Tony.
Thanks, Adrian. I just want to go on from what Beth was saying on dentistry. I think we seem to have a particular problem with dentistry at the moment, particularly with children. And it appears to me that what's happened is the dentists sort of together, many of them decided that the funding wasn't right for them, and they've gone private, and leaving a shortage of dentists to do vital community work. And I just think the only answer to this is somehow we're going to have to pay them a bit more to renegotiate their thing. And there doesn't seem to be any other way around that, and probably to recruit a few more dentists as well. But you know, I don't see another way, really.
I mean, I don't know if Helen wants to come in as well, but I think you're right, absolutely. And I think that the issue we have is as a national contract. So all of these sort of healthcare contracts are more nationally driven. And the other thing to note is all of those professionals, they are all independent businesses as well. So it is that commercial factor. So, you know, as opposed to Helen and I, who are employed by the NHS, and we've got the NHS badge on our logos, they are commissioned and they are private organisations, which makes things a little bit more complex in terms of having to work with these, with the healthcare professionals. But I think, yeah, go on, Helen, if you want to.
Unfortunately, there's no magic answer. I don't think on dentistry. It really is an area that we're really concerned about, and I know that residents are too. So Sanjay's outlined, and it says in the strategy some of the things that we're doing to make our commissioning as flexible as possible, to be able to focus the funding that we have on particular groups or areas of particular need, and to try and support and encourage dentists to take that up. But it is a really challenging area, largely subject to national contract negotiations, as you've alluded to. And I know an area that we've discussed here before and are likely to discuss again. But we have tried to make sure we're covering it off in the strategy, and that we're exploring all options with regard to how we resolve those issues.
Thank you. Alison?
Thank you. I've got two separate points. Has this been sort of independently reviewed by a comms team to ensure that the language and the way you're expressing things is really accessible. As Phil said, and I think we all agree, we want, you know, a very wide range of our residents to respond to this. And some of this, I mean, there's one bit that says supporting staff practice to the top of their licence. I don't know what it means. I also think the noun and the verb are being confused there. Building dental clinical workforce resilience. I think there are several parts that, you know, I had to concentrate quite hard to work out what you meant. And I've been on this committee and, you know, looking at these documents for many years. So, and here at Woking Borough Council, we now ensure that all our communications with residents are examined very carefully to make sure that we are using straightforward, clear English to people.
Just to say thank you for that comment. And I think we'll make sure that happens. To also say that there on the website we have got an easy read version as well, and so there is that version on there. But I think you make a good point of when we publish the final one. We will take that into account. And I'll make sure our comms teams know. But as I said, there is an easy read version as well out there. So if there's a patient who wants that one, that is available as well.
Well, I just think, you know, it could be clearer English without needing to say we've now rewritten it for people with a reading age of 10.
Yeah. Okay.
You know,
yeah.
There is. I think when you're in it,
yes,
it's very difficult for you to see that.
No, thank you for that.
Sorry, my second point, coming to. I mean, I hope that we are going to be able to see direct referrals. I mean, 3 times, like I've been for my eye test, and they've told me, oh, we're a bit concerned about your cholesterol level. It's something that we can see in your eyes. But if I ring my surgery and say, oh, my optometrist has recommended I have a blood test to check my cholesterol. Oh, no, you've got to make an appointment to see a GP. I don't want to be taking up a GP's appointment when I know how precious they are. And, you know, I would like to see, and that's a high street service. Also, you know, you go there and have hearing tests now. I was told, you know, you have got some hearing loss, but they couldn't, because I was under 55, they couldn't refer me. I am now, but I wasn't. They couldn't refer me directly to RBH. I had to have a telephone. I had to have a GP's appointment for that to happen. And I just think we really need to be cutting.
Yeah, but the bottleneck.
Respect for professionals who say you need a referral, and you know, having a whole GP appointment for that, you know, is just mad.
I don't want to continue with. You know, we all know there's bottlenecks, and you know, absolutely agree with that point. Was Alice? Did you have another question?
Yeah, I was going to ask Sanjay, do we have this in different languages as well? Because there's also that bit as well. Because our cohorts in Wokingham, there's an increase of ethnically diverse communities. So do we have this in different languages?
Oh, sorry. I'm sure there is actually, but I'll double check, Alice, and I'll let you know actually.
Thank you.
I want to summarise this now. So there are a number of very positive things you brought to the table. Obviously, that's really pleasing. You know, the change in pharmacy is sensible. You know, I remember taking up GP appointments for some cream for athlete's foot, which is just ludicrous. Agreeing with the points raised by Alison. But some of the other questions don't go away, you know. You mentioned FNA. I've been on this committee 6 years. Nobody's ever said FNA to me. Sorry, PNA. Pharmacy needs phonetic spelling. Apologies. But you know, it's absolutely clear with Lloyd's exit and various other things going on in different pharmacies, etc., that would look something quite different now compared to early 2023. But since I first joined this committee 6 years ago, I've been asking questions. Well, residents have always asked me, number one topic, GP service access. So I was asking the CCG for 4 years, you know, are you sure you've got the right algorithm for allocating GP services? Because Wokingham has built big estates all around it, and we've got the same or less GP service than we had 25 years ago when we first arrived here. The population in the last 10 years has gone up 15%. The under 15s has gone up 15%, and over 70s, I think it is, has gone up 43%. So the population is completely different than it was 10 years ago. So I would like to see a GP NA, a GP needs assessment. I would like to understand what that is, how we get onto that, how we progress that forward. When I spoke to a GP surgery in the PPG, the lead GP was there and he was very quiet and he let everybody else talk for 2 hours. And then I had a one-to-one with him and he said, you know, this surgery was built for, I don't know, 6,000 or 8,000 people. And we very quickly got over that. And then we got to 10,000. And then we got to 12,000. And now we're at 15,000. The building can't cope with the number of patients, the number of treatments, assessments, etc. And he is saying to me, he's talking to whoever he can in Bob or whoever, CCG, saying, you know, I can set up a satellite practice in Wokingham. I can staff it. I can get a building. I can get a practice and get a GP in it. Why can't I do that? And he said that he's never been given a satisfactory answer to that question. So why would we not let a GP who's saying he's ready to go with everything to increase the capacity when we know Woking Medical Centre has over 25,000 patients, and they're just in the process of building out massive estates just over that way that are going to go to Woking Medical Centre. We know that these places are completely overloaded. Look at the waiting rooms, look at the queue. Last time I went to Woking Medical Centre, they were queuing out the door. The pharmacy in Woking Medical Centre had 8 people working machines like this. And it was rammed with people asking for prescriptions. This is not new. This has been developing for 25 years. And frankly, it's very hard for me to sit here and listen to the answer that the allocation is correct. I find that incredibly difficult to take, because what I see on the ground is that's simply not true. And that's what the GPs say to me. It's what I see in the pharmacies. It's what all the residents tell me. The residents are not making this up. The residents are really, really struggling. I know some of the initiatives, and you mentioned the excellent idea of Pharmacy One. I know things are changing, but the need is huge, and I really don't feel that we're addressing it correctly. And, you know, I've spoken before to Helen saying, what do we have to do? What questions do we need to answer to say to you, hey, you know, our population is completely different than it was 20 years ago. Why, you know, we really should have another GP practice or additional services somehow. So that is the question that I don't want you to give me an answer. I want some of the strategies really good, don't get me wrong, but when it moves into implementation, that is when we get really interested, because then we start to see KPIs and we start to see numbers. I mean, Woodley GP surgery gave a fantastic presentation. I can't remember the head GP there, but she's brilliant. Yeah, she's brilliant. And she gave this presentation and she said, these are the KPIs coming out of our automated telephone system. We saw 1,300 people on the first Monday of the month, because RBH or Frimley or whatever are trying to move people out of hospital, put them on long-term care plans where they see the GP once a week or once every 2 weeks. And, there's more and more. And she was, you could see the pain in her eyes from, we are trying to deliver the best service we can, but we are really, really under intense load. And I had so much empathy for her and her team, and she thought perhaps I'm wrong. Yeah, so she went out and they did a comparative, which I believe was with RBH, which is number of telephone calls and how quickly they're turned around. And the outside comparative said that they could not believe the throughput that the Woodley surgeries were doing, that it was actually astronomical numbers of people communicated with directly on the telephone and assessed by a GP or a team member, and they said, you're delivering an amazing service considering the huge numbers you're getting. So this is not just one GP. This is all the GPs in this area under this enormous pressure. And the GP that I had a year ago, he quit his job as the GP to move to a research thing, because he said to me that he has 10 minutes, he has all his processes, his updates to do, his prescriptions to make, his notes to make, and everything else, and then he's bam into another complex case, then another complex case. And he was at that surgery 6 months, 9 months, and then he said, I just can't cope. I absolutely can't cope with this load. That's one aspect, is a never-ending question around GP access and the size of Wokingham. And I don't want any answers on that. The other question I wanted to bring up, which was mentioned by Tony, last week, Phil and I represented this committee at the joint Bob Hosk, and one of the councillors representing, I think it was Oxfordshire, he's an ex-dentist, and obviously he knows this topic inside out. But he had question after question after question about dentistry, and then I heard on the radio shortly afterwards that the NHS bill for removing complete teeth from children has gone up 50% to £81 million last year, because children's teeth are not being cared for, because the NHS is not supporting their needs effectively. So again, I don't want any response, but every meeting I go to, dentistry is all over every meeting, and that and GP access are really, really burning at the moment. And I think in your responses, Helen, you're really absolutely aware that dentistry is a really difficult issue, and something that will take a lot of work, shall we say. But thank you very much for coming, and we really appreciate your time, and lovely to meet you, Sanjay. Thanks very much.
That's great, thank you. And we will take all of your comments on board. Obviously, you've not asked for an answer on those points, but happy to have further discussion as appropriate.
Super, thank you very much, Helen. And then I think we've got, is this a separate item, this integrated care board update? Yes.
Well, yes, we provided this item for information, really. Yeah. So this is a regular report. It's primarily to health and wellbeing boards. It's directed, but provides just a general update on some of the key areas that the ICB is working on and would want to make people aware of. Quite a bit of this document actually focuses on the primary care strategy, which I think we've already discussed, but there are some other updates with regard to the recent board meeting the COVID and flu vaccination programme, and also highlighting our stakeholder newsletter, which again is another way that interested parties can find out more about the work that the ICB is doing.
Do we have any questions on this topic?
Sorry, it's me again. With regards to the backlog that's been created by continual strikes that we have, is there any special plan that you've got to be able to bring those numbers back in line, or are you just hoping that they're going to organically, that by extending waiting lists, become part of the norm?
Okay, so this isn't an area that I'm directly involved in. However, obviously within the report, we've highlighted the impact of the earlier phases of industrial action. We'll be undertaking a similar analysis based on the more recent periods, and that will be factored into the work that is ongoing to reduce the waiting times. But it is extremely challenging. I'm happy to get some more information for you if you would like.
So, yes, of course, please do.
Because sitting on sitting on the governing body of the RBH as well, it's something that we've been discussing, and it might be worth speaking to them about their plans to bring it in, because of course they've been so directly affected by strikes. I'm sure those discussions are going on, but as I'm not party to them directly for the committee, we can get some more information. But yeah, happy to link with them. Thank you.
Super. Thanks very much for your time. Lovely to see you. Hopefully see you again soon. Thank you. Lovely to meet you, Sanjay. Thank you. I think it's Alice next, I think, if you'd like to give us a quick update. Alice, that'd be fantastic. Thank you.
Thank you, Chair. Can you hear me? Yeah, can hear me. Good evening, everyone. I have shared with you all the report, and I'm not going to narrate any more. Is there any questions that you would like to ask me based on the report that I have shared? It would be nice to have a discussion about it. I mean, as I said, the recruitment of volunteers, we're still, we are still doing that, and also the visibility of Health Watch as well. One of the things that has happened very much so when we did the GP Access project, we were very aware that people did not know about Health Watch. But after the GP Access project, we've had a lot of people come to us and have conversations about the services, and how difficult it has been. So one of the things that I would like to make you all aware of is our GP Access project that started in October, and we went round Wokingham, and I've shared with you where we've been. So we've had 150 surveys, including focus group discussions about the new way of working, and also the care navigators as well as the NHS app. The report is going to be coming out in end of March, and then we hopefully will be shared with the Integrated Care Board as well. So that's what we are also planning to do. I mean, when you look at our engagement has been we've done face-to-face as well as online, in order to give people a chance, especially those who are not able to meet us at like a 9 to 5. So we've had people come and have a conversation with us on the online. So we've had two online events, and also we went to Waitrose to have a conversation with the service service users there, and also the cafe staff. So that's been a really, really big project. And just to share with you that it is a Berkshire West project. So we've had Reading, Wokingham, as well as West Berkshire. All together, that's over 300 surveys that is being analysed at the moment. And then the next one that I'm sharing with you is dentistry and learning disability. Like you all, dentistry is a big topic, and we wanted to ask people with learning disability, what their experience is. And, we've only had 14 people share with us. However, the themes that are coming out, one of them is dentists don't explain to you what's going to be happening. They don't understand about they don't understand about learning disability. So those are things that we are going to be trying to answer. Then, like every year, we go out to the public and ask them about the health and social care priorities. That's also going to be coming out in end of February, and it'll be out for a month. So we are also going to be doing focus groups, meeting groups to go to find out what their priorities are, and that will be used to for our work plan. So, and that's where we are at the moment. And also want to just share with you as well, we've had increase in our staff as well. So we are going to have staff in the hub every week, every day, which is good for us to be visible, but also they'll be also doing a lot more engagement in the community as well. If there's any questions, I'm happy to answer.
Can I start the questions? And really, obviously, I want to thank you for all the work you're doing and engaging with all these different areas. And it's really good news to hear that there's going to be a representative in the hub on a regular basis. That is absolutely one of the key aspects of Health Watch, to check the pulse, as you were, of the community, of the residents that we serve. So I would be very interested to see how that goes and your feedback in the next report on that. I've got some additional requests for you. If you haven't got enough work already, I've got more requests for you. One of the things that constantly gnaws away at the back of my brain is that the PPG for Woking Medical Centre doesn't appear to exist. I think you have a statutory responsibility as Health Watch, and I think you need to, it would be helpful for me as the chair of this committee if we could get you to formally email or present them with a letter or something to say, where the hell is the PPG? Where are the meeting minutes for it? Who's on the PPG? When is it next going to convene? Can I talk to them? I would like you to say, hey, lead practitioner of Woking Medical Centre, it's my responsibility to represent the residents of Wokingham, and I have a statutory responsibility under XYZ to understand your patients. Therefore, I want to talk to the PPG, and I want you to do it in a very formal way, and I want to see what their response is.
Can I just share that, when we did the entrant view, about a year ago, 6 months ago, just to share with you that we are reviewing that report. So we have a duty to review that report. So and we are going back to the Wokingham Medical Centre to look at our recommendations. Today, I've also shared that we are going to Wokingham Medical Centre to the primary care, integrated care board, primary care as well. So they are going to be asking questions before we go in. So I'll come back to you guys next time to share.
That'd be great. That's perfect. But also, I'm very keen on, hopefully we live in a democracy and hopefully we care about every single area. So I'm also interested in the North PCN, early and South and everywhere. So my ideal scenario as being chair of this committee is that you get an engagement with every PPG for these 5 PCNs. And if you don't get an engagement for each of these 5 PCNs, then we can escalate this further and say again to the ICB, where is the PPG for this PCN? Because, you know, I'm going to keep asking this question, and perhaps until the coroners need to take me away in a box. But I find it really disturbing that we're missing a PPG from a critical, a very large PCN in our area is not being covered by a PPG, or it appears to be not being covered.
So can I just share that we, one of our engagement officers, we've just appointed a senior engagement officer who will be looking at all the PPGs, because so we are scoping to see what's in place and not in place. So I'm hoping that I can share. Well, I think he's just started, so I'm going to give him a chance. But that is his objective, to go around all the surgeries to find out about the PPGs, how they work, because it's a contractual requirement for GP surgeries. So that will be happening. But he's just only started. This is the second week, so he's
okay.
So that will happen soon.
But I will be very keen to see that update. And obviously, Helen confirmed herself at the last meeting, which is minuted in our minutes, that this is a contractual requirement for whoever's providing GP services. They must have a PPG. So I want to see 5 for these 5 PCNs.
I can update you then. Not a problem.
That would be fantastic. Thank you. Of course. Please go ahead.
Can I just ask you a question on this, if I may? I don't know what Woodley Church is. Where is Woodley Church? Woodley what church?
It's the Emmanuel Church.
But if you say Woodley Church, I don't know any. There's several of us here from Woodley would know where that was. If you said Emmanuel, yes,
yeah,
we would know.
I think, yeah.
Can you change that, please?
Yeah, I will. Not a problem.
Jackie?
Never see Shinfield mentioned.
Sorry?
We had this before, about a year ago, but Shinfield's never included. Is there a reason?
Calling Shinfield.
When we did this project, we went out. So if you look at the south, we went out to and informed everybody that we were doing this project. So Shinfield was informed, Swallowfield was informed, and Finch Hampstead. So we encouraged them all to come to Arborfield, because that's when the availability of the hall was. So
well, I'll go and have a chat with them. So they didn't become involved.
Well, we shared the comments with them. And the things that what I would like to do is, when I come back with the full report, you will see which surgeries engaged with us.
Sure. Thank you very much.
Alison.
But Beth asked, as I would have done, which Woodley Church it was. I'd also ask which Waitrose, Twyford, Wokingham, Woodley?
The Wokingham ones. So I'll be very specific.
Please, it's not all Wokingham centric. I can't presume that. And I was really pleased to hear you said that you were having engagement opportunities for those who work 9 to 5. Well, if you work 9 to 5, you don't get home till a lot later than that. Could you expand a little bit more on when those sessions were?
We did a morning session in different areas. We also did an afternoon session so that people could come. So the sessions were like.
Sorry, when did you do them outside working hours? Do you mean you did one at sort of 8 in the morning, or?
Oh no, in the evening. So it was an online event. So we did it in the evening, so that people could engage. We didn't do a physical one.
Okay, so the outside working hours was only online sessions?
Yes.
Thank you.
Super. Thank you so much, Alice. Good to see you. Lovely
Okay.
to see that beautiful smiling face. Thank you so much.
Thank you.
And have a good few weeks, and we look forward to seeing you next time. Thank you very much for your support.
Thank you.
Do you want to do the forward program?
Okay, so the forward program is set out on page 55 for our last meeting of the municipal year. So we have South Central Ambulance, the primary care update from the ICB, which is like the third paper that you had today, and hopefully, if available, the report from Health Watch on GP's new way of working in the NHS app, and the adult social care KPIs if it fits in with the cycle. You'll see currently unscheduled topics on the forward programme. So it's not that they've been forgotten, it's just they will be populated for the new municipal year. But did anyone have any comments or changes you want to make?
So not quite on this, but just for the new municipal year, I mean, there may be different members on this committee, but is there a glossary of all these initials? Because I must admit, I keep forgetting what they all mean. I mean,
we can do one.
It's full of, and I can't remember what they all are. I still don't know what a PPG is. I'm trying to work it out.
Al, no question is a stupid question for this committee. And I think that's a very good one because, when I joined this committee, it was total hieroglyphics and gobbledygook. And, we are still getting to grips with things like the ICB, let alone anything else. So it's a good point. But yes, if there's no further questions or comments, I would like. Oh, Jackie.
This really fits in, but I just noticed down here currently unscheduled topics: vaping in primary school children. My granddaughter's just gone to Holt, and she was telling me that one of the girls got set off the fire alarm because she was vaping. So it's obviously rife, isn't it, with kids at the moment? It's frightening. So that's obviously so important that we might have to have a chat about it. So yeah, shocked.
I mean, it's Rishi Sunak's changing the law at the moment to get rid of these throwaway ones, which I think is a very good idea. But yes, agreed. Shahid, you've got a point or a question?
Yes, so very quickly, not on the forward program, just on the point which we were discussing earlier on regarding CT scan. Actually, the cost, which I asked earlier on in the cost, right? And actually, I've done some, just for everybody's information, I did some investigation, and I know the people who actually got some quote as well. It could be anything between $850 to $1,250 getting a scan, right? So obviously, it's a huge cost. And thank you, Adrian, for your comment as well, which you just shared with me. But can you just imagine? I mean, this country, obviously, we know. Unfortunately, death is quite expensive. It's cost literally thousands of pounds with the funeral directors and all the cost included. And this being on top of that as well, say approximately £850 to £1,000. And that's a huge cost, especially at a family when it's a very distressful time. So I don't know whether as a committee, what can we do? But I think this is a service, we shouldn't, they have to pay for it, but I don't know how to go about and do this.
Yeah, so this topic, I completely support what you said earlier, but this applies, as far as I'm concerned, to every single resident, whatever their colour, whatever their religion, it is totally irrelevant. I feel that if their religious or cultural beliefs necessitate something like this, then it must be a free service. Because a person with a different religion or a different colour would have a normal autopsy, which would be free. They wouldn't have to pay for that. So why should anybody have to pay for an autopsy CT scan? I absolutely hate this, and that's why I said to those the coroner guys, I was so disappointed with their answers in that particular area. I would, join you with a campaign. I would highlight this certainly to the leader of the council, certainly to the chief exec. So any case, and this applies to anybody who is aware, but anybody that's getting a bill for an autopsy, I think it is totally wrong. I mean, I don't know. I'm enraged about it.
Thanks, Adrian. I'll talk to you afterwards when you take it offline.
Yeah.
Thank you.
Yeah,
Thank
but
you.
any support I can give you through Stephen as a leader of the council, or anything that I can do, I will support you 100%.
Thank you.
If there's no further business, then thank you very much, everyone. See you in March.